Go to your medicine cabinet right now or picture exactly what is in it, because the answer to what I am about to tell you is almost certainly sitting on one of its shelves, not behind a prescription label, not something a doctor called in after a serious diagnosis. Something you bought yourself, over the counter, without a second thought, probably more than once in the last 30 days. A painkiller, the kind that works reliably, the kind you have been using for years, the kind that handles a headache before it becomes a full day lost, or a sore knee after a long walk, or lower back pain that arrives without warning and stays longer than it used to. Millions of adults over 60 reach for this medication more than any other single drug in their home, and the vast majority of them have never been told what it does to their kidneys every single time they swallow it. Not because the information doesn't exist, it does, published in nephrology journals, flagged by the Food and Drug Administration, documented in the clinical guidelines of the National Kidney Foundation, but because nobody has translated it into plain language and delivered it directly to the people who need it most. Dr. Melanie Honig, a nephrologist at Harvard Medical School and Beth Israel Deaconess Medical Center, who has spent her career studying drug-induced kidney damage in older adults, has written in clinical reviews that non-steroidal anti-inflammatory drugs, NSAIDs, represent one of the most significant and underappreciated threats to kidney health in adults over 60, and that the damage they cause frequently develops without a single symptom until the point at which meaningful, sometimes irreversible harm has already been done. The painkiller is ibuprofen, it is Advil, it is Motrin, it is naproxen, it is Aleve. It is the medication sitting in more medicine cabinets across this country than almost anything else, and what it does inside the aging kidney is something that every person over 60 deserves to understand before they open that bottle again. To understand why this happens, you need to understand one thing about how healthy kidneys function, and the explanation is simpler than most people expect. The kidneys filter approximately 50 gallons of blood every single day, and to do that work at the pressure and volume required, they depend on a group of chemical messengers called prostaglandins. Prostaglandins are not just involved in inflammation and pain, they are the kidney's primary mechanism for dilating the small blood vessels that feed its filtering units, called nephrons, with the blood flow they need to operate. When prostaglandin activity is sufficient, blood flows freely into the nephrons, filtration runs at normal efficiency, and waste is cleared. NSAIDs work by blocking the enzymes that produce prostaglandins throughout the body, which is exactly why they reduce pain and inflammation so effectively. But that same blockade occurs in the kidney simultaneously. Blood vessels that depend on prostaglandins to stay open begin to constrict. Blood flow to the nephrons drops. Filtration efficiency falls. And if the kidney is already operating under any kind of additional stress, dehydration, elevated blood pressure, concurrent medication, reduced baseline function, that drop in blood flow can trigger what nephrologists call acute kidney injury, a rapid deterioration in kidney function that, in older adults, carries a significantly higher risk of progressing to chronic kidney disease than the same event in a younger person. A study published in the American Journal of Kidney Diseases found that short-term NSAID use in adults over 60 increased the risk of acute kidney injury by over 50% compared to non-users, and that risk was not limited to high doses or prolonged use. Even standard doses, used for a few consecutive days, were sufficient to produce measurable changes in kidney function in a meaningful percentage of older participants. Here is why 60 is the number that matters, and why this risk is categorically different for you than it was 10 or 20 years ago. The kidney loses functional capacity with age at a rate of approximately 1% per year starting in the mid-40s, a decline that is normal, expected, and that most people never notice because the kidney has a remarkable reserve capacity designed to absorb this loss without producing symptoms. By 65, the average adult has lost between 20 and 30% of their kidney's peak functional capacity. By 75, that number can approach 40%. None of this shows up as illness. None of it causes pain or obvious symptoms. It simply means that the kidney's margin for absorbing additional stress, from dehydration, from illness, from surgery, from medication, has narrowed significantly. The same NSAID dose that a 40-year-old processes without consequence lands on a kidney that is already working harder to compensate for reduced reserve. The same 2-day course of Aleve for a back flare-up that caused no detectable harm at 50 now occurs in a kidney with measurably less capacity to absorb the drop in blood flow that follows. And because the damage is cumulative, because each episode of reduced renal blood flow leaves the kidney slightly less capable of recovering fully than before, the pattern of occasional routine NSAID use across years quietly erodes function in a way that blood pressure tests, cholesterol panels, and even annual physical examinations almost never catch, because the test that measures it is almost never ordered proactively. There is a second layer to this risk that is so important and so broadly unknown among older adults that nephrologists have given it its own clinical name, the triple whammy. It refers to a specific, extremely common, and genuinely dangerous drug combination that occurs when a person takes an NSAID alongside two other medication classes that are among the most frequently prescribed drugs for adults over 60. The first is an ACE inhibitor, or an ARB. Medications like lisinopril, enalapril, losartan, and valsartan, prescribed to millions of older adults for high blood pressure and heart protection. The second is a diuretic. Medications like hydrochlorothiazide or furosemide, also prescribed for blood pressure, heart failure, and fluid management. Each of these three drug classes affects kidney blood flow through a different mechanism. Together, in combination, their effects on renal circulation compound in a way that dramatically and measurably elevates the risk of acute kidney injury beyond what any single drug produces alone. Research published in the British Medical Journal analyzing nearly 500,000 patient records found that the combination of all three, an NSAID, an ACE inhibitor or ARB, and a diuretic, was associated with a risk of acute kidney injury more than 30 times higher than baseline in the first 30 days of combined use. Not 3 times, not 10 times, 30 times. And the critical reality is that an older adult with high blood pressure who reaches into their medicine cabinet for ibuprofen or Aleve for a back flare-up is, in tens of millions of cases, already taking one or both of the other two classes without ever having been told that the combination creates a clinically recognized, named, documented danger. Their cardiologist prescribed the lisinopril. Their primary care physician prescribed the hydrochlorothiazide, and the ibuprofen is on the shelf because it always has been. Nobody connected the three dots. The reason this damage is so dangerous beyond the kidney injury itself is that it progresses without the signals that normally drive people to seek care. There is no acute pain, the kidneys do not have nerve endings that register injury the way a muscle or a joint does. But there are 5 specific observable changes the body produces when the kidneys are under sustained or repeated stress, and every adult over 60 should know them by name. The first is foamy or frothy urine, a persistent bubbling or foam that remains after the toilet flushes, which occurs because damaged nephrons are allowing protein to leak into the urine that healthy kidneys would retain. A single foamy void means little. Foam that appears consistently across multiple days is the kidney signaling that its filtration barrier has been compromised. The second is swelling in the feet, ankles, or lower legs that is not explained by heat, prolonged standing, or a long flight. What physicians call edema, which occurs when the kidneys fail to regulate fluid excretion properly and fluid accumulates in dependent tissues. The third is high blood pressure that is becoming harder to control with existing medication, because the kidney plays the primary long-term role in blood pressure regulation, and when its function deteriorates, the feedback systems that maintain pressure become dysregulated in a way that manifests as resistance to previously effective treatment. The fourth is fatigue, with no satisfying explanation. A specific tiredness that does not improve with rest. Driven by the accumulation of waste products, the compromised kidney is no longer clearing efficiently from the blood. And the fifth is a reduction in urine output that the person may not notice unless they are specifically paying attention. Not dramatic enough to be alarming on its own, but meaningful when it occurs alongside any of the other 4 signals on this list. None of these 5 signs are loud. None of them will drive most people to an emergency room. And that is precisely what makes them the 5 things worth watching for specifically. Here is what you do with all of this. First, look at every medication you currently take, prescription and over-the-counter, and identify whether you are on an ACE inhibitor or ARB for blood pressure, a diuretic for blood pressure or fluid management, or both. If you are on either or both of those medications, ibuprofen and naproxen should not be your default painkiller for any reason, and your physician needs to know if you have been using them. Bring this specific information to your next appointment because the triple whammy combination is not a risk that most prescribing physicians communicate proactively, and the responsibility for connecting those three medications in the patient's daily reality rarely falls clearly on any single provider. Second, ask your physician to add a basic kidney function panel to your next blood draw if one has not been run in the past year, specifically a serum creatinine level and a calculated eGFR, which stands for estimated glomerular filtration rate. This is the number that directly measures how efficiently your kidneys are filtering blood, and it is the number that will show early-stage decline years before any symptom appears. An eGFR above 60 is generally considered within the normal range for adults over 60. A result below 60 on two separate tests, at least 3 months apart, meets the diagnostic threshold for chronic kidney disease. This test is inexpensive, it is part of a standard metabolic panel, and it is the one piece of information that will tell you whether any of the silent damage already discussed has begun. Third, for pain management going forward, ask your physician specifically about acetaminophen, sold as Tylenol, which does not carry the same kidney risk as NSAIDs and remains appropriate for most older adults at doses below the daily ceiling. The National Kidney Foundation explicitly recommends acetaminophen as the preferred over-the-counter analgesic for adults with kidney concerns or kidney disease. The ceiling for adults over 60 is generally 2 grams per day, not the 4-gram maximum listed on the label for younger adults, and that distinction matters. The medication in your cabinet that you have been trusting for years is not something to fear unreasonably, but it is something to use with information you may not have had until right now. Your kidneys have been doing their work silently for 60 years or more, without a single complaint, without a warning, without a symptom. They are asking for the same courtesy in return. 30 seconds of informed decision-making before you reach for the bottle the next time your back flares, because an eGFR number and a conversation about your blood pressure medications may be the most important investment in the next decade of your health that you make this year.